Welcome to the final closing session, which I think has a very interesting title. It's the knowledge perspective of evidence-based policymaking. We've heard already a lot during the course of the day about the work of the panel and how that contributes to the various processes. It's time maybe to take a bit of an even more strategic perspective at the end of this day. And of course, the role that the scientific community plays and can play in bridging this gap we have been hearing about for most of the day between scientific evidence and policy making. And in particular, of course, we are all aware, policy making is not just for policymakers. Policy making happens in a specific context. So also the media, the general public, how do they relate? How can we ensure that there is also a communication, a dialogue, a discussion, a presentation of this knowledge and expertise also? Because you cannot have, and I speak here with my hat as someone involved for many years in public policy, you cannot do good policy making if you try to do it in isolation. That's a recipe for failure, disastrous failure. In most cases. So we should also maybe reflect a bit on that. And to help us out with this very difficult question, we have a distinguished panel. I'd just like to introduce Dr. Emily Karafilakis, a researcher from the London School of Hygiene and Tropical Medicine, and Professor Dr. Paul Barak from the Wayne State University School of Medicine, who will give us their insights. I understand you have presentations. Yes. So I'd like to give the floor first to Dr. Karafilakis for her presentation.
Thank you. I think I have two small disclosures. First one, I'm coming from the Vaccine Confidence Project, so a lot of the examples that I'll use are going to be vaccination-based. Second one, as you'll very quickly see, I am not an expert in evidence-based policies and how to use expert knowledge to inform policies. That's not necessarily my area. My area is more about how to look at the public and how we can better listen to the public and how that can inform in itself policies, which is, there are some similarities. But when I was asked to talk here at this event, I was struggling a little bit to find what the connections are. And that's where this came from, which is very, very simplistic model of my understanding. I mean, when we think about knowledge translation, evidence-based policies, we tend to think about experts, policymaking, right? Policymakers, how the two of them interact and how they work together to develop better policies. But what about the public? Knowledge translation, again, when we think about it in a very simple way, we think about experts talking both, translating their scientific evidence into a language that policymakers understand on the one side, but also on the other side, a language that the public understands. So this is our typical traditional view of looking at this. But we need to understand a little bit more about knowledge translation in the terms of the knowledge coming from the public itself. How can we translate the public knowledge into evidence for experts and into evidence for policymakers? Especially as we are today in a world where these type of events keep on happening. We are demanding, we are seeing the public becoming more and more engaged in policies, whether we want it or not, whether it's in health, in environmental issues, political issues, gun control. The public is becoming more and more involved in policies in one way or another. Their opinions, their values, their insights are influencing what we are doing on a political level. And a very sort of more theoretical way of looking at this, we live in a world now that we can call a culture of risk, a risk culture. So we live in a world where technologies have become a lot more important. We're dealing with technologies in all aspects of our lives. That's one thing. So they're more universal, they're more unavoidable. They're more difficult to control, and they're also more difficult to measure and assess. So this is one key point. So in order to deal with all these technologies and these risks, whether that's vaccination or others, we need to deal with them in different ways. Either we need a really highly technical knowledge of these problems, so that's where experts come in, for example, or we need to take a leap of faith. And that's what usually we request the public to do. Trust us when we're telling you what to do. Trust us when we're telling you what is beneficial, what is risky. We will tell you we know best. That's the typical model that we've seen. But living in a risk culture means that at the same time, what we're trying to do, and we see this with governments, with health authorities, with different policymakers, we're trying to ask people and encourage people to take control over these risks that are becoming more unavoidable. So we're asking them to take control over their own lives, to start assessing themselves the risks and benefits, and look at the internet, and look at, sort of assess themselves how to make decisions. The way this is addressed in health is what we call healthyism. So we talk about patient empowerment, having patients that can make the best decisions for themselves. But that also obviously comes with its own risk. We've seen that with vaccination. When we ask people to make decisions, they don't always make the decisions that we would like them to make. And that comes with a bit of a problem. People have different opinions. Sometimes when we ask people to make these decisions, some of them will fight very much for the pro-vaccine, to sometimes using arguments that are not always correct on one way either, but also they can be very anti. So how do we deal with knowing that we need to listen to the public? They are having more and more of a role in politics, and we need to include them, but they themselves don't really know and can't agree on what they think is important. We also have to be careful not to shut them down. In one way, if we ask patients to become more self-empowered, we can't suddenly take away that control. And that's why when I'm hearing in a lot of conferences people criticizing Dr. Google, saying, well, you know, all the patients, they come with the doctors with a pile of leaflets printed for the internet, and they ask Dr. Google before they even ask us. I think we need to be very careful about our criticism of that, because it's true that they can find misinformation, but we should take the fact that patients are becoming more engaged and more empowered as a benefit. Trying to change the conversation. We will not change what we're seeing with the internet, the social media. We will now have more empowered, more engaged patients. What we need to do is think about how to change our relationship with patients, with the public, taking that into account. Not to erase Dr. Google, but to work with that together. So an example of when things go wrong is when the government listens to the public directly without necessarily listening to the experts. So that's just one example of what happened in Japan with HPV vaccination. When they introduced the vaccine, very quickly some parents started complaining about symptoms that their girls were developing. And they were convinced that the symptoms were related to the HPV vaccine. So they started filing lawsuits against the vaccine manufacturers. They started complaining in the media. You had stories all over the media from parents claiming that the vaccine was causing these symptoms in their girls. And what happened is that the government listened to parents without listening to the experts. So in that certain case, they listened to what the parents had to say, and even when the WHO declared that the symptoms were actually not linked to the vaccine, and where scientists, experts that actually looked at the issue in Japan, in those girls, stated that there was no link between the vaccine and these symptoms, the government didn't listen, and they stopped recommending the vaccine based on the public's concerns. So that's one thing, and as you can see, the coverage decreased for HPV vaccination to less than 5%, and it also had an impact on the coverage of other vaccines, childhood vaccination. So that's an example of how we can go wrong as well when we listen to parents without taking into account as well the role of experts. Other side, again, HPV, but this time in Colombia. We had cases of girls developing some symptoms in a school. These were dizziness, nausea, spasms, and we very quickly saw that it spread across schools to about 600 girls in the country. This was categorized as mass psychogenic illnesses. So that's reactions that you get that are linked to anxiety in relation to the vaccine rather than a biological element of the vaccine. So it's more of an anxietal reaction. The problem is that the government here didn't listen to the experts that were telling them how to talk to the public, and they called this a mass psychogenic illness, and the girls felt like they were accused of making up their symptoms. People felt like they were calling them crazy, that it was all in their head. So that's, again, another example of how it can go wrong if you don't listen not only to the public, but also the experts that tell you how to listen and how to work with the public. So in the end, it's about finding the right balance. It's about looking at the public, the information, the experts, the scientific knowledge, and trying to see how we can work better together. So it's about trying to see how the public can inform scientific experts, and also how that can influence policymakers, and how scientific experts can relate that information to the policymakers. So one way to do that, one way that we can listen, if you look at it from the expert and public perspective, there are countless ways of trying to develop better understanding of what the people think. So for vaccination, we've developed that sort of wheel that looks at all the different ways that we can collect data to try to give a voice to the people and understand how they feel. Our key conclusion is that one metric doesn't tell the whole story. Quantitative surveys isn't enough. Qualitative surveys isn't enough. We can go online as well. There are so many tools that tell the whole story that we need to combine together. So now looking at it from the side of the public and the policymakers, so how can the policymakers better listen to the public? So there are different ways that this can be done. I have here 3 examples. One of them is the report that the expert panel produced. It's about using, again, the expert as an intermediary of scientists, researchers that understand and can research how the public feels and what they mean. In the center, it's about citizen consultation. So this was done in France when they realized that they were one of the countries in the world with the lowest confidence in vaccines. They organized a debate with citizens to try to inform their policies. And they asked them, what do you think about mandatory vaccination? And this actually came as a suggestion from the public. So their decision to make vaccination mandatory came from a public consultation and came from citizens themselves. And lastly, it's about co-creation of documents. So when you are creating, whether that's vaccination campaigns, communication campaigns, you need to think about engaging with the public. This leaflet here was created in the UK, and the logo that you see, Arm Yourself Against Cervical Cancer, was very much loved by the patients themselves and by the girls that loved the idea of having the arm in arm together as a symbol as well of standing together, but also the arm that would get vaccinated. So it's important to include the patients in your communication activities and development of policies. That should I come earlier. And lastly, communication with the public. We too often think about communication as a one-way process, as how we're communicating to the public. We have our findings, this is what we want to tell people, this is what will make them better. So many people talk about the problem of vaccine hesitancy as just a problem of information. It's just that people don't know. If they knew the risks and benefits of vaccination, they would vaccinate. That is so far away from the actual solution. It's about communicating with. It's a two-way process. As I said, we need to engage people in policy making in itself. And I don't want to go, I mean, it's not about giving you a lecture on how to communicate, because there are so many good tools that do that, and training as well that are important to take on how we can communicate. But there are a few tips that are valid both for policymakers and for experts, because experts are some of the worst communicators, I think, that exist. And I can say that because I'm a researcher as well. I can't say anything about policymakers, but researchers and policymakers can take a few tips. Be incredible. So do not withhold information. to just avoid embarrassment if you think that something is going wrong, or to avoid panic. That will create the panic. Express empathy. So many times we see people that are being judged, that are being that are not being listened to when they express their concerns. Showing respect. We talked about being paternalistic earlier today. I think that's really a key thing. So listening to the people. Don't judge or dismiss concerns. Be the first to provide information. So if something happens, if people are starting to lose trust, if you start to see rumors circulating, you need to be the first one out there before that gap is filled by anti-vaccination groups, for example. Being accurate, so that's where your experts come in and trying to get the best possible evidence at the time. If you don't have the full evidence, it shouldn't prevent you from communicating. It should just mean that you have to adapt your communication. Think about how you communicate. Most scientists will use scientific facts and statistics and figures, and will lose everyone in the room. Promote action. So that's the key thing. It's about how people, and it comes back to self-empowerment, it's about how people can feel engaged. I feel like they're doing something, they're making decisions. We shouldn't take away that right. People are more engaged. We shouldn't now say vaccination is the norm. People should just vaccinate and they should stop asking questions. I hear this still so many times, and this is so wrong on so many levels. So we have to be very, very careful about this. And the last point is just about the language. I think if we're not careful enough, we risk really missing the point and contributing to the misinformation that spreads. This is an article that was published after the WHO's announcement that vaccine hesitancy was one of the top 10 global threats. The way it was reported, and that's CNN, but it was reported in many other newspapers, is anti-vaxxers. And there was actually another article that says how to inject ourselves or something, anyway, it's polarizing the debate. It's thinking that people are all these really crazy people on the one end, these anti-vaxxers, they're not normal people, they're really extreme. And if we categorize everyone in that group, that clearly shows that we haven't taken the time to listen to what people actually think. Because if we listen, we'd know that actually most of these people that are not vaccinating are simply parents that are trying to do what's best for their children. Thanks.
Thank you very much. Lots of food for thought and some excellent advice, I think, there. And yes, as policymakers, we're also guilty as charged very often, unfortunately. So lots to reflect on there. Of course, all that we just heard is certainly not something which is unique to Europe by any stretch of the imagination. And we're very glad to have with us also Professor Barack from the US. How does this, what you've just heard today, relate to your own professional experience and the insight you could also give us from your perspective?
Thank you. I'm going to stand up only because it's late, and I want to make sure that people in the back can see me. So thank you for inviting me. I know many of you wonder why I'm here, since I'm not full-time in Europe. First, I have no financial disclosures. I think it's important that we're very clear about that. So I highlighted in yellow some of my work in Europe for the last 10 years with a lot of universities, including being a principal investigator on a grant and working on several grants. And so it's been wonderful to have some insight into the European marketplace. They say outsiders see much more than insiders, but lack context. So perhaps that's an interesting, given that Martin maligned my country earlier. And I joke because I never meant to talk about the US that way. But it was so interesting that it's so easy to assume that the other side of the pond is worse, better, fill in the blank. And so with that said, and I'll get back to the vaccines, this is where I live as a clinician. And I've not heard enough said today. At the end of the day, if we're going to make healthcare better, the people that live in these spaces have to own these policies. Pharmacists, nurses, doctors, physical therapists. Unless we make sure that they're on side, they'll do three things. Number one, they'll sabotage the policy, and they're master saboteurs. Number two, they'll burn out. And right now, the burnout in North America, Australia, and Europe is ranging to 40 to 50%. Last year, 302 physicians committed suicide in the US. Twice the rate for age and income adjusted. The key risk factor is being a male surgeon or a male anesthesiologist. And they're not totally disconnected from what we're talking about today, and yet we haven't really talked about the wellness of providers. Nurses that change jobs regularly don't want to go back to work after delivering babies, et cetera, et cetera. I think that's part of the conversation, that we have to focus more on the unintended consequences of these things. So here's the question. How do I treat the patient in front of me given all these lovely policy reports? Because that's what the nurses, physicians, pharmacists in Europe are going to ask themselves when they read your reports. What does it mean to me? Not in a silly, selfish way. What do I do with it? How do I act on it? And this little cartoon between a caterpillar and a butterfly reminds me that we tell them, just listen, just change your behavior. And they're like, I'm not going to change my behavior because I can't see how it's going to help me. And I think this is quite important. So I thought, as a way to start, here's a balloonist says, where am I? And the fisherman says, you're 30 meters above the ground in a balloon. You must be a researcher, says the balloonist. I am. How'd you know? Well, to tell me the truth, you've told me perfect information, but it's useless. So the farmer says, you must be a policymaker. And the balloonist says, yes, but how did you know? Because you don't know where you are, you don't know where you're going, and now you're blaming me. Many, many providers feel that policymakers are blaming them. And think about the EMR. Perhaps you've seen what's happened in Epic in Copenhagen, a mass pushback after Epic decided to install an American, not good system into a European system while ignoring the concerns of the nurses and physicians, leading to a massive uproar. So bad that people outside the capital city refuse to get the system even free. That's how bad it's become in Denmark. There are other examples, but it's a nice one to showcase very clearly that the providers in Denmark who decided, or the policymakers to buy the system, could have seen that in the US, the #1 cause of unhappiness by nurses and doctors is electronic medical records. They knew that before they bought the system, but Epic said, we'll give you half price, don't worry. It's a terrible example of corporate imperialism, and it's worthwhile looking deeply into that. So the question I've not heard enough talk about today is that how do our systems learn? Are we learning? And how are we measuring the scale of learning? At the end of the day, that's what systems have to do. We've known that for decades and decades. So just a few examples on the gap, and I want to talk about the gap in surgical safety because it's a huge and important one. These are top hospitals in the US, ranked very highly. In the last year, they've had extraordinarily adverse events. Johns Hopkins, Vanderbilt, UNC, Chapel Hill, massive events which are not suddenly happening. They're just bubbling up. Warren Buffett, the famous investor, has this saying, when you're at the waterside, the seaside, and the water goes down, you can see who's naked and who's wearing a bathing suit. I feel the water is going down in healthcare, which is what's exposing a lot of our systematic problems, our organizational structural problems that are being exposed. So here's the gap. On the top right is the ARIS human that was mentioned earlier. This is the recent one that came out 20 years later. On the bottom right is the Lancet Commission. In the middle is OECD, led by Niek Klasinga and his team. And to the left is OECD. This is what we know 20 years after we've talked about safety, particularly surgical safety. This is an extraordinary failure of policy and implementation at the end of the day. So, did you know that surgical deaths are the 3rd leading cause of death? This is the Lancet Commission 3 months ago. Not in the operating room, but when you leave the operating room, your risk goes up 1,000-fold. 1,000-fold. So we've made the operating room really, really safe. But we haven't focused on what happens a day later, 3 days later, or a month later. This is a problem. Now, while I, as an anesthetist, perhaps might think it's not a problem, I think the problem is an incredible problem, and it could have been forestalled, and it could have been understood. So I want you to think about the 4 T's. We've talked about trust. We've talked about transparency. We've talked about truth-telling. We haven't talked about the most important T, which is teams, and the science of teams and how it's relevant. So 105 years ago, one of the most important people in modern medicine, Ernst Kadmon, got fired out of my alma mater, the Mass General Hospital, because he said in the cartoon, I wonder if we tell the golden ostrich how bad our care is, will she still lay those golden eggs? They immediately fired him. So then he went to Chicago and set up the Joint Commission. The Kadmon Award in the US is the highest award for quality. 105 years later, when he said surgeons should share their data with the public, remarkable, 105 years later. So a few months ago, We've known this for a while, but now the hard evidence. Surgeons that misbehave in the operating room, patients die more often. It's not just not nice to have surgeons throw things and be disruptive. It actually kills patients. We've known this for a long time. We haven't acted on it for a variety of reasons. We know in Europe that in the same intensive care units, the same drugs, the same protocols, if the culture is toxic, more patients die. Let me say that once more. Irrespective of the evidence of the right drug, if the culture is toxic as manifested by bullying, shaming, things like that, patients die more often. This data is at least 10 years old. Even New England Journal of Medicine 4 months ago published a paper that said the single most important thing in improving quality is psychological safety. Imagine that for a moment. Not the right drug, not the right bug. Those staff feel safe speaking up. We must talk about this aspect where staff don't feel comfortable. I talked before with some UK representatives about the fact that colleagues in the UK, when they speak up, sometimes they get put on garden leave. This lovely term, which means you're taken off the job, you're still being paid, but you're at home. And it's essentially a euphemism for the fact that you've spoken up. So this idea of scapegoating and blaming people that speak up. We just got this paper published. I thought I'd share with you. This was just from a few days ago. 10 years of data out of Norway demonstrating very clearly that when nurses feel unsafe and management feels disengaged, patients die more often, and we've been able to quantify it across half of Norway, 2.5 million patients. Again, our gut feelings, our heuristics, we have harder evidence now to show that engaging the staff, middle management feeling they own the problem has consequences. We must talk more about these connections. Here's the data more clearly. When the culture shows you there's problems, patients die more likely. It's not just a soft science. This is the hard science. The culture, the trust, the engagement, the truth-telling. You all know about surgical checklists, right? They work, right? Except they don't when you don't believe in them and the staff is disengaged. This is Canada, Ontario, a wonderful system. Zero benefit from 18 months of surgical checklists. Zero benefit. And it happened because the teams were completely ignored. The hospital was told, unless you have 100% compliance, we're going to cut your reimbursement, and we're not even going to analyze the data with you. We're just going to publish it. A terrible recipe to shame and blame and ultimately lead to no benefits. We've learned this from other industries. Without trust, if you continue to measure, here's what clinicians say. I don't trust your metrics. I don't like how you look at me. I don't think your methods are valid. I don't like you. You don't understand what I do. Anybody ever hear that before? Okay, this is the model. We need to focus on trust-building measures amongst our team members. Otherwise, we're going to have more and more measures, more and more data. We're drowning in data. I was the chief quality officer of a 1,200-bed hospital. I had 18 people just collecting data. No dearth of data. That's not the problem. The problem is what to do with all this data and how to action it. This is even before the super digitalization of medicine. How many of you have heard about Team Steps? So 15 years ago, we developed this. This is an evidence-based program to support teams in primary care, secondary, and tertiary care. This is the data. 18% reduction in mortality. 18%, published in JAMA, 108,000 patients. How many of you have structured team training in your hospitals? Not one hand maybe. So this is a gap. This is 20 years old. The data we took from the military, from aviation, from Formula One teams in Italy, from the All Blacks rugby team down in New Zealand. What can we do to improve the quality of primary care teams, of surgical teams, et cetera, et cetera? In year 2000, we published this paper and we said, what could we learn from aviation? Again, we know this stuff. The question is, do we have the courage and the leadership to implement it? Primarily, in this case, is surgical teams, so it's not limited to surgical teams by any yardstick. Miracle on the Hudson. Is it evidence or is it intuition? Do you know about this story? Right? So we'll come to that. I want you to think about that for a moment. So one of my teachers, Donald Schoen, who's 91, has a new book just come out, has this wonderful book. And he argues that health policy is not some high, lofty, high ground thing, but it's more like a swamp with predators and muck and alligators. And I hope I didn't excite you. But, and so the point is, of course, that we need to understand that in that swamp of real policy, there's all kind of forces undermining the data. So this is work that we published several years ago in the BMJ with Richard Lilford, arguing that the more left you go, the more impact you have on the system, but the less you understand the context and culture. So when you make policies at the level of the ministry, you have no clue what's happening at the wards. And this is a problem. How do we bring the policymakers closer to nurses, pharmacists, intensivists, and surgeons? I think that's essential if we're going to make the data what we call sense-making. Carl Weick's magical word, unless clinicians trust it, they will find ways to work around it. This is the most important person in industrial change. We don't teach this to nurses and doctors and managers. This is the reason why systems work. Deming, 75 years ago, argued that if you don't understand your processes, if you don't teach change management, you can't get improvement except at the margins. Could this explain why we still don't have proper training of nurses, doctors, and managers in system science? Again, more system science. These models come from Denmark. Denmark was the first place in the world to think about this. Jens Rasmussen. In every country in Europe, every industry except healthcare uses this. We, maybe a little bit. Unclear why we have to learn the hard way, why we are not humble enough to learn from our pilots, our nuclear power regulators, and every other high-risk industry. I have no time to talk more about it, but there's lots and lots of work on that. So a few examples. We talked about surgical. We don't deal with this issue, what happens when the patient leaves the hospital. We know that monitoring patients for at least 30 days can save perhaps 10% of morbidity and mortality. So there's a lot of information on wireless monitoring, but we need to be thinking about what happens when the patient leaves the ward, rapid response teams, and the like. This is a project we're doing in Europe, 220 hospitals, looking at, there is no data in Europe on this, what is the mortality of patients having surgery after the age of 70? And it looks like it's quite high. It's about 15%, which is remarkable. But there is no data in the US. The only good study is from in the US is from 2005. In Europe, there is no good data. This is an important study, self-funded because it never rose above the threshold. So very interesting study that needs to be discussed more, further. So the role of co-design and patients, we know very clearly, we've talked a lot about this. It's not just about asking patients. I think, like PCORI in the US, that every project funded by the European Commission should mandate that there's real patients on the study team. That's what's happening in the US with PCORI. NIH is moving in that direction. In Australia, the ARC is moving in that direction. In the UK, NIHR is moving in that direction. Not just symbolic, not tokenistic, no more tokens, all right? Real patients that will be part of teams working with clinicians to help make sure that this isn't lost and it's not a footnote at the end of the report. I don't think that works as well as integrating patients within the research teams. We did this work in Europe. This is Project Handover. We looked at readmission problems. I've talked to several of you today. That's still a huge issue. We published 29 papers from the study, and still we're struggling with how to get patients involved around readmissions and why primary care docs and hospital docs don't talk well to each other, which is remarkable given that so much of this was funded by the European Commission, but it wasn't implemented because the Commission said that has to be done at the state level, and the states didn't want to allocate funds for it. These are some of the papers. Again, there's much more that I can share with you. We don't talk enough about the built environment, how the building itself, we know very clearly it shapes, it causes noise, it causes infections. So bringing the architects and engineers, so we think about new facility design, how it shapes flow, joy, light. We know a lot about this. We need to study it more clearly and how it connects to outcomes of healthcare systems. Again, how do we get beyond the state of technology will save me? Here's a question for you. Do any of you have any data if gamification works in your patient mixes? So I reviewed it last week. There is zero data, zero published data that gamification makes a difference. Challenge me if you have any data. I'd love to hear it. Now, it doesn't mean there's not potential value, but the myth that companies are pushing forward, in the US, it's like if you do this, you'll live longer, you'll save your patients. We don't have that data yet, so we have to be very clear about the analysis so we don't continue this mythology which makes us all feel guilty. Why aren't we all rushing forward to hire these companies? This is a story in Norway last year. Perhaps you heard about this. Multiple European newspapers ran stories about fake applications to European FDAs. And what became apparent was that it's very, very easy to get approval of devices in Europe. So we wrote an editorial, which is now called the Seoul Manifesto, which demands that medical device approval have at least the thresholds of drug approval. There is no registry for devices right now. There should be next year with the MDR. But again, there's a lot of European health ministers pushing back against the MDR, saying it'll undermine industry. The question is, how will it undermine patient safety? We know quite a bit about these problems in the US. This is from the UK, the Health Foundation. Again, are our systems learning? We should be asking ourselves, how does this play in your own countries? Are you regularly learning from every adverse event? And if not, why not? There's only 2 countries in Europe that have separate agencies for learning. One is the UK and one is Norway. Not regulatory bodies. These are bodies for one purpose only, to learn from every process and outcome failure, like in aviation, and feed it back into the health systems. I think it should be in every country. And finally, there should be one across all of Europe, just like there is in aviation. There's no problem with that from data security. It's de-identified. It's not a problem whatsoever in aviation. Again, using Bayes' theorem, we've shown there is no need to study handover randomized controlled trials because there's no way you're ever going to have enough power. So we have to use adaptive trials. We have to use Bayesian trials. We have to use different types of trials because RCTs give you negative answers. And the more you do it, the more negativity you get. Finally, this issue of formula for success, again, context, culture, we've talked a lot about. I'm not going to say more about this. We haven't talked about this. A very important paper by Mary Dixon Woods and others showing that unless you have a theory for change, you'll never understand why your intervention worked. That means you have to study change management. It's a scientific domain. It should be part of nursing schools, management schools, and medical schools in Europe. And it's not right now, as far as I can tell. It's starting in the US, starting in Canada, but still too slow to be across the system. Again, this idea of why does it work, and how does it work, and how do we sustain the gains when we move from one hospital to one country across the European consortium. Again, we know quite a bit about this. We published this 15 years ago. We need to be able to translate these lessons into everyday things. So let's not forget John Kotter, Management 101. Unless there's an urgency, health policy won't change. So again, the question is this a burning platform? Because in many, many countries, healthcare is turning into be the #1 reason in political dogfights. The final T we haven't talked enough about is transparency. Most publics don't know outcomes in healthcare, and most doctors have no clue in the outcomes in their own wards. You ask a typical nurse, how many patients have fallen in your ward last year? They go, I don't know. But somebody knows in the hospital. Why don't we give the staff the data on their outcomes? This is from Don Berwick's report to the NHS, indicator dashboards. So every nurse and every doctor and every manager has the data. So they believe that the policy interventions are based on real data, not what this too shall pass. Because we know, like the 4-hour rule in the UK, most clinicians thought it was bollocks. Like the Brits say, it was worthless. And in fact, in Australia, Martin, they copied. You know what happened? Numerous rooms proliferated next to the A&E, and the sign was non-A&E rooms, and patients were moved at 3 hours and 59 minutes. So never underestimate the unintended consequences of bad policy. Just never, because you never know how it's going to happen. Finally, training. We haven't talked about learning and training. We must upskill our healthcare staffs in improvement science. That means for managers, nurses, doctors, and of course, educating patients what to ask for around scientific formations of quality. But what about these things? Have we not talked enough about empathy, compassion, kindness, engagement, harmony, and joy? How does that happen with all these changes? So I hope the commission, the next report will be on how do we protect the soul of the future providers? Because the data suggests mass unhappiness, really a serious problem, and it's an epidemic of sorts. And if it was infectious diseases, it would be a pandemic. There's no question about that. So, in final conclusion, this is how system science people think about improvement. We have to redesign the process. We got to deal with our culture that's toxic in many levels. And finally, we must include human factors engineering and science like any other industry in Europe. We have to stop thinking that we're special because we're not. Our systems are no different than any other system out there, except we deal with patients, but our systems, our technology, our interfaces, our buildings are very much aligned with any other high reliable industry in Europe. And so we need to think about that. My final slide, culture always trumps rules and standards and European Commission policies. What can you do? We got to deal with culture, And of course, Peter Drucker's famous quote, "Culture eats strategy for breakfast, lunch, and dinner." The truth is that it's like a goblin in the room. We got to deal with it. There are tools to measure it. There are tools to change it. It takes a long time. So let's be honest about the fact that this might take 5, 10, 15 years. And finally, back to Captain Sullenberger. Here's what he said. "One way of looking at my success was that for 42 years, I've been making small, regular deposits in the bank of experience, education, and training. On January 15th, the balance was enough, so I could make a very large withdrawal." That is wisdom after 42 years. So just think about that when you watch the movie, about how the regulators tried to kill him because he decided to break the rules, which is really, really very interesting. So in conclusion, we have to create physical and organizational environments that support patients and staffs to create respectful interactions, which are under risk right now. Engaging clinicians, patients, and the community remains a big obstacle. The lack of engagement is a serious problem. Facility design affects the work and supports the culture. And finally, challenging clinicians and managers without engaging their values and their overall environment is not sustainable. It simply will not wash. They're too smart. They know how to play the system better than you'll ever know how to play the system. So we have to understand how we socialize them. And then, of course, Avidis dan obedience, the secret of quality is love. Thank you.
Thank you so much. That's really very impressive, and I think it exposes a lot of the system failures we have. I think that's really something we need to reflect on also for the future, and the kind of not just thinking of evidence in terms of strictly, empirical terms, but also in terms of understanding how we can learn also from these kind of issues. So thank you very much for that. We have time just for maybe 1 or 2 burning questions, if there are any, because we're running slightly late. And I don't want to keep you here unnecessarily on a Friday afternoon, but I think these presentations probably will have elicited some questions. If not, we can move to a Slido, where you can express all this collectively. So, where's the Slido? I think the question is, in your opinion, what are the main enablers of evidence-based policymaking? So that's the question. Okay, hope the system is working. Okay, answers coming in. Pretty even match so far, but there's still more people, I think, voting, so let's continue. Stabilizing even more. So. With these kind of presentations, I always have the question whether there's tactical voting going on. Okay. Seems to have. Okay. Anyone still left to vote? No, it seems to have stabilized. Okay. So it looks like the governance structures actually are deemed to be, the most important thing to foster these interactions. And then pretty much the other factors are ranked pretty equal. Proactive communication by academia and experts, the high-level political support, for that, and also the sharing of best practices and concrete. That's also the importance of peer reviews. That's pretty much all. The last three are pretty much equal. Okay, so that's very. I think it demonstrates that it's a multifactorial aspect, and all this is important, and therefore we need to also factor in quite a number of considerations. Okay, so thank you very much. I'd like to give the floor now to Professor Jan de Messener, the chair of the expert panel, who has the difficult task of wrapping up the discussions today, but also looking ahead at future challenges following all this that we've just heard over the course of the day. Please.
So, good afternoon. It has been a long day, and so I want to be short. Just looking back shortly, it will be almost one slide, and then to confront you with some ideas about the future. And these are not my ideas, these are the ideas of the panel, because we did a brainstorming to prepare this. But before starting with that, I just want to tell an anecdote. A week ago, I was at the European Parliament in Strasbourg. Yes. And I have to say, I've never been there. That was a quite moving experience to be there and to see how nowadays there are seats for 28 countries. And that gave me the sense of the value of bringing the unity in this continent, and the importance of the European Union to contribute to that. And thinking about that, I was reflecting on, and what is the small thing we can contribute as an expert panel to make this happen. And of course, that makes you very modest when you are at that place. But nevertheless, I think that the people that you see on this slide and on the next slide did their best in the previous 6 years to try to make 18 opinions that tell a little bit what could go better if we use the evidence and translate it into policy. And certainly for today, the feeling that we have is that some of these ideas really took their way in the structures, found their way in the European Commission, also in NGOs, also with other stakeholders. And for us, this gives a very positive feeling. On the next slide, you see all the names of the people that contributed. And you see, it's not such a big group. And I think it was intensive work that made this happen. Looking back, next slide, what were the things that come up to my mind? First of all, our strength was our diversity, but our strength was also our commitment and the expertise we had. Interdisciplinary team, and as I said already, we learned to explore the richness of transdisciplinarity, and maybe the most important thing when I look back, what makes this different from all the other teams I was working with, well, the team of experts became a group of friends. And I think that was a very important evolution. And looking back, for me, that is what made the drive, the commitment, but also the quality and the productivity of this group is that we really became a group of friends where there was not the feeling, this is my domain, this is your domain. No, it's our project, and we have to help each other in order to make the best out of it. And I think that this is important, and I think it comes back to what Professor Baraks told, the importance of relationships also when you, at any level, be it on management, be it in clinical care, be it also from the patient side. Yeah, these relationships are extremely important because they shape the process, but also they determine the outcome. And so this is, I think, a very important message. What we also appreciated was our relationship changed with the DG Sante and the Commission. For instance, and it was already explained, in the way we were discussing the questions, the formulation of the terms of reference, that started quite top-down, but very quickly it became a process. And the first thing we did was talking about, reflecting on the terms of reference. And sometimes it took the first 2-3 weeks to make the terms of reference, the way that we could live with it from both sides. And I think that was an important process. And it comes back also to what was told by Emily, I think, when you say, well, you have to interact and you have to find a common ground. That's with the public, that's also between science on the one hand and policy on the other hand. And finding the common ground is a very important experience. And of course, we also had interaction with not only the EC. I have very good memories of our meetings in Brussels with members of the European Parliament, with member states at different levels. With the regions was also very important. We presented our work in the regions, with academics at academic meetings, with a variety of stakeholders, and very often also with the public and with patients. And I think that also contributed to the relevance. As was said, if you don't know what happens at the ground floor, at the grassroots, it will be difficult to be relevant in your message and in the way you're functioning. But let's look now at the future. And some of the questions that come out of today also is, well, what in the future can we do to strengthen the European Union and contribute to a social Europe? Because I'm more and more convinced, and also the panel, is that we have a task in making European Union a more attractive project, especially also for the youngsters in Europe. If we are not able to translate EU in a project that will be attractive, that will build a social Europe, I think there is quite a risk for our future. And so the European Pillar of Social Rights certainly creates opportunities, but also can we integrate in the broader global aims like the SDGs, which was already mentioned also during this day. Also, the question, what is an acceptable and effective mix of policy evidence? And we know that you don't have only medical evidence, you have contextual evidence, you have policy evidence, and I think the three are important. And opinion, because not all questions are answered. And I think it was interesting to hear your feedback of all of you today about the way we did it in the past 6 years. How to address the organizational and operational aspects of healthcare within the actual legislative framework where Europe has not so much to say about this. The Maastricht Treaty is very clear. We cannot say to member state, you should organize gatekeeping, something like that. No, we can't do that. So how can we be operational within the actual legislative framework? What is an appropriate mix of, on the one hand, operational recommendations and strategic advice? And we always balance in between both. And I think that's not bad, because operational recommendations translate your vision, your opinion into action. But on the other hand, you want to contribute to a more global, a better underpinned debate when it comes to strategy for the future. And it's always a balance to strike. And then we decided to make a brainstorming exercise in the beginning of this year and to see, well, if we can think out of the box as panel, what would we write up? And we came up with 6 points. And I'll run quickly through it. First point was, we think it is important to increase the accountability for realizing the EU dream for improvement of citizens' health. We thought it is important to talk about a new dream for citizens' health. Let citizens dream about the health system in the European Union. Let us create world-class centers for health care, focusing on the benefits for citizens. And of course, there is quite a lot. The SDGs are there. I talked also about European Pillar, the 20 key principles. However, whilst there is undoubtable commitment to these goals, actually, there is presently no mechanism to ensure accountability for progress towards these goals and aspirations in the European Union. And that's a problem. That is in marked contrast to the process that incorporates within the European semester, whereby the Commission provides country reports and makes recommendations to correct and coordinate macroeconomic imbalances. And so we think maybe we should see if there's a possibility that the state of health in the EU reports, Sylvain Giraud talked about that, which provide factual comparative data on health and health systems in the member states, how could that lead to more explicit recommendations? Could that be the basis for a system of accountability for at least the health element of the pillar of social rights? That are questions that we want to put forward, and certainly, of course, that should be debated within European Commission to see if we can create more accountability. But besides creating a positive attitude towards health systems and pride regarding the achievements of European health systems, it will be important that we demonstrate what we made already. And today, for me, was also important, and for all of us in the panel, because we saw some demonstration of what little changes we have been able to make. And I think that it is important in Europe that we strengthen the understanding of the positive contribution of health systems for individuals, communities, and societies, directly and indirectly, because that can create an atmosphere in which the EU dream for health and health systems receive more support and will be shared. This is relevant given that achieving important SDGs for health and well-being will crucially depend on the risk and income solidarity to ensure affordability and accessibility also of those worse off in terms of health and wealth. And we may not forget recent publications in the Lancet have demonstrated that democracy is good for health. I think that's also an important lesson for Europe. Second point. The creation of learning communities to bring together the best expertise, experience and practices in the EU. It is a conclusion of at least half of our opinions end with this conclusion. Maybe we have a question to the European Commission. Can we investigate, maybe with some pilot initiatives, how this could work in practice? Because to bridge the gap between the population on the one hand and the panel and the European Commission on the other hand, this kind of learning communities could provide a platform to bridge the gap and to have direct contacts. Next slide. Third point, strengthening EU protection for healthcare. The panel agreed that strengthening financial protection from healthcare spending is very important. Provide protection through a collective at EU level instaured mechanism of reinsurance of resources for healthcare in member states in order to avoid that national economic and financial crises decrease access to healthcare for the citizens living in a certain member state. When I was in Greece at the moment of the crisis, European economic crisis, it was terrible to see that people did not have possibility to access healthcare. How can you be a project that is oriented to the future and that has the trust of your citizens if you cannot guarantee access to healthcare, irrespective of the economic situation of the country you are living in? And I think that is an important thing, and we all agreed upon that. It was important to make that clear, and we even have indications that there is a basis to make that happen. In a recent survey in Europe in relation to a similar mechanism of protecting unemployment allowances, that shows a strong adherence for a mechanism based on broad solidarity by a varied group of citizens and stakeholders in the member states. 20,000 people in Europe filled in this survey. And what we saw was there was a very much strong support for the most solidarity-based principle. So there is room in Europe to think about these kind of things, and I think it's important to start that process. Reduce health inequities. Reduction of unjustified health inequalities is an ubiquitous policy objective, but progress remains very slow. Equity considerations need to be included more systematically in the design of policy interventions and in the financing of health systems. And I think in many of our opinions, we came back to that. And of course, that will require cross-sectoral policies, as has already been said in many of the interventions. Next slide. Point 4, investing in real health promotion and prevention. I think it reiterates what has been said in our last opinion, but also in many interventions, This is a critical role for health promotion and disease prevention nowadays, and to engage in a dialogue, avoiding blaming the victim, but in a dialogue that stimulates and creates opportunities for citizens to improve their health and to realize a positive health concept. And of course, therefore, it could be important that we try to find ways to see if we can be in Europe a leading center for innovation in transformative health promotion and prevention policy, research and practice at a pan-European level, and establishing a European knowledge translation function to support member states in the effective use of scientific research in order to enhance population health in Europe. Number 5, we look out of Europe. The panel is convinced that it is not possible to realize health in 2030, 2040 in Europe if we are not looking at the South and especially at Africa. Addressing the health effects of migration through capacity building for healthcare in Africa, actively migration and refugee crisis, climate change and capacity building for healthcare, for education, for food production in the global South are strongly interrelated. More and more literature illustrates the links between migration, climate change, capacity building, and even fair trade. EU policy could address these issues in an integrated and comprehensive way, looking at the push and the pull factors, at socio-economic and ecological drivers. This requires EU to take a leading role in a new dialogue with African countries, and this could be operationalized both at research level and at the level of development aid and capacity building. Personally, as I'm working for more than 22 years already in capacity building in Africa, I think this is a key issue. And it is, I think, essential for our survival, even in Europe. If we don't address this issue, I think there will be a dramatic outcome. 6, development of new models of care in an affordable way. Of course, we discussed and we studied a lot of new models of care, value-based, shifting of tasks, primary care in the community, and so on. And of course, it is important that there are mechanisms to support member states when they engage in transition processes. For instance, helping member states in adopting and adjusting to new models of care that could go hand in hand with good decisions on the financial side. But it is very important that if you want to shift, for instance, your care from hospital to the community, what all member states will have to do in the next 10 years, then there is a difficult moment. That is a transition phase, because you have to pay twice at that moment. You have still your hospital and you have to develop your primary care. Could it not be, we suggested an idea to see to what extent we could help in this transition period the member states that helped them to make their shift, looking at transition costs and how at the European level we could intervene to help the transitions happen. These are just some suggestions we made, but it illustrates also that the panel will not stop, it does not stop to think at the opinion level. We try to look further. We try also to create a future and a perspective for the future. Next slide, please. So we need input for that by all stakeholders, and we are very happy that we also have good contacts with WHO, with OECD, with the observatory, and we work together. And now also 2 members of the actual panel were in the National Academy of Medicine. So even, Professor Barak, we could make a bridge to the United States from the panel, so that is very important. You will have the last word, you, the audience here, because we will, Martin will ask you something. Next slide, to give an input. But before we do that, I want, on behalf of all the team members, thanks DG Santé, everybody, for the help, the possibility, the trust, and the creativity that we are allowed to demonstrate in all our work, and especially also to the staff that helped us to make all things concrete. I will not name the people because then you risk to forget, but during all the process there have been very committed and skilled people that have helped us to do our work. And I think that's very important. And finally, I want to thank the panel members. It was a wonderful journey together, and it was a privilege to be your chair. Thank you.
Thank you very much, Professor de Meissonier, and indeed, it is we who should thank you and all the other members of the panel because you have made an invaluable contribution. I mean, the past 5 years have been very important. The evidence that you have provided through your opinions, I can assure you, played a key role in helping the Commission identify also the issues that have now been also laid out politically. We do not underestimate the extent of this challenge. We have, I think, ahead of us an agenda that I can only describe as very ambitious, but absolutely necessary. Absolutely necessary. And we can only do that if we have access to the best possible evidence base. I mean, these issues are challenging in their own right, but I think if we pool our efforts together, the expertise that is available, as the panel has done, and with the help of others as well, I think we can start to at least have a better handle on these issues for the benefit of our societies. And indeed, this is the main role. This is why we are here in the European Union. We know the priorities of the next Commission. They've already been identified politically. Many of these are issues that are very, very complex. If we speak about the cancer plan, the European health data space, the issue of how to achieve innovation, affordability and access, perhaps one of the biggest, most complex issues we have ever tackled in health policy in the history of the European Commission. The challenges posed by antimicrobial resistance and also the issues of vaccination, the many issues around vaccination, but also more broadly looking ahead to the SDGs as the overarching priority for the Commission. Also the Green Deal, the aspect of environment will bring out also a lot of interrelation with health and the importance that health plays in that. So lots of work ahead. So while, of course, the current membership of this panel is coming to an end, but clearly we can already have a very clear vision of the extent to which we will continue to need expert advice for the coming years. So, but I would like to take this opportunity to really thank the members of the panel, congratulate them on the excellent work. Indeed, the team spirit was remarkable. That was very apparent. And also I think we had a very good working relationship between us in DG Santé and the panel. It was indeed very much a collaborative exercise. And this needs to continue. This must continue. Because again, we still, of course, have a lot of questions we need to have answered, and we need to dig deeper into some of the issues, as has already been said. We are, of course, soon going to be appointing the new panel, the new group of experts to serve in the panel. There has been a call for application, a selection procedure that I can assure you has been very careful. But I'm also very glad to note the high level of interest in this panel from academics. This is very good because we always have a moment of trepidation when we issue such calls. You always worry what will the response rate be like. But it was excellent. It was excellent, and I think that shows as well that there is a real feeling that we now are at a very important, maybe watershed, in health and public health. I am convinced the panel will continue to bring added value to the work we are doing. We also should discuss how we can bring this wealth of evidence to the attention not just of the Commission, I can assure that is already the case, but also to the national administrations, because that's where a lot of things need to happen. And also to citizens in general, the many stakeholders. We are very privileged in the health area to work with very committed and very knowledgeable stakeholders. And that's a great asset. That really makes our job as policymakers much easier. So that's really important. So, but as Professor de Meissonier has promised, you will have the last word, as is fitting. So we have another Slido, the final Slido of the day, and this is a kind of word cloud approach. So we would ask you to suggest a possible subject for an expert panel opinion. So the first thing that you would think of if we were to give you this role. What would you suggest as one of the next topic that the expert panel should handle? And already we see first couple of suggestions, others coming in as well. Seems you'll have a lot of questions to ask, but it's very good. And indeed, a lot of these are indeed interrelated. So that's good also that some issues are coming up. Okay. Yeah. So I think, from what we can see, it's clear that for some themes are resonating quite strongly, but I think we recognize this is all very interrelated. And indeed, one of the areas where we also maybe is to better understand these interrelationships. Sometimes when you're doing public policy, you are aware it's a very complex chessboard, and sometimes moving one piece creates all kind of impacts elsewhere on the board. And that's very often where things can go wrong. So, and that's particularly where expertise and advice is needed. So thank you very much for that. I assure you we'll have ample opportunity also in the coming months to define this agenda with the new panel and, of course, consultation with stakeholders. And the political agenda of the incoming Commission, of course, has already identified issues that will need a lot of input. So we look forward definitely to that collaboration with all of you. So thank you very much. Thank you for a very fruitful day. And thanks once again to the panel members. And we look forward to the work ahead. Thank you very much. Have a nice weekend. Thank you.